Hi there. I'm so excited to welcome you to the Arthritis Life podcast, where we share arthritis life stories and tips for thriving with autoimmune arthritis. My name is Cheryl Crow, and I am passionate about helping people navigate real life with arthritis beyond joint pain. I've been living with rheumatoid arthritis for 20 years, and I'm also a mom, occupational therapist, video creator, support group leader, and I created the Room to Thrive self-management program. I am so excited to help you live a more empowered life with arthritis. We're going to cover everything from kitchen life hacks to navigating the healthcare system to coping with friends who just don't get it. Seriously, no topic is going to be off limits on this podcast. My interviewees and I share our honest stories of how chronic illness affects our lives. This includes discussions about mental health, sex, shame, pregnancy, body image, advocacy, self-acceptance, and so much more. You'll hear stories from all ends of the spectrum, from a person who's living in medicated remission from psoriatic arthritis to somebody living with severe mobility restrictions and severe pain from rheumatoid arthritis. You'll hear how people manage their conditions in different ways, like medications, mindfulness, movement, social support, work accommodations, and so much more. You'll also hear from rheumatology experts who just get it. We'll dive deep into the science behind chronic pain and what's the latest evidence for lifestyle changes that can help you thrive with arthritis, including exercise, sleep, nutrition, stress reduction, and more. This is your chance to sit down and chat with a friend who's been there. Ready to figure out how to manage your arthritis life? Let's get started.
Welcome to Rumor Has It, the podcast that busts myths, highlights evidence, and inspires hope for living better with rheumatic disease.
Through plain language, interviews with experts, we offer actual knowledge so you can thrive today.
My name is Eileen.
And my name is Cheryl.
Join us as we bust myths and spotlight evidence.
Hey, we're so excited today to have Dr. Christine Stamatos to talk about fibromyalgia myths versus facts. Dr. Stamatos, can you first let us know a little bit about your training and how you came to specialize in rheumatology and fibromyalgia in particular?
Oh, thank you. Yes. So I've been training for a while, or I've been in practice for a while. I'm a nurse. I went and got a master's degree, and then I became a nurse practitioner and then got a doctorate at Stony Brook University. And my focus during my doctoral program was the non-pharmacologic and pharmacologic management of chronic pain. I got into that because I was already involved in rheumatology. And I found as a nurse in all the rheumatology practices, so by this time I had been in 3 rheumatology practices, and each one of those practices, any of the patients that had fibromyalgia somehow always ended up on my panel. And I think it's because fibromyalgia is not an easy condition to identify, to treat, and you're always making sure that you're looking to find other explanations for your symptoms. I was determined to see what else I could offer patients, because it's not just about the medications that we put into our body. As you mentioned earlier, I've done a talk called Not Another Pill. It really is a whole armamentarium of strategies that cut across both self-management skills, basic lifestyle medicine, and Western medicine, and socialization. I mean, it takes all of that to feel well when you live with a chronic, in this condition, pain state, such as fibromyalgia.
Thank you so much. And Eileen has a question for you now.
Yeah, and I'm really excited to have you here today because I have seen you speak at ACR, and also as somebody living with fibromyalgia on top of my rheumatoid arthritis diagnosis, I personally find fibromyalgia very confusing, and there is very little information, resources, or anything kind of given to us rheumatic disease patients. We're kind of diagnosed with it and told to kind of carry on with what we're doing. So I'm really excited to have you here today to talk about fibromyalgia.
Can I touch on that issue that you just mentioned? So fibromyalgia can exist all by itself. You can have fibromyalgia without another condition. But I'll tell you that between 30 to, in some epidemiologic studies, it's up to 60 or 70% of patients who carry a rheumatic disease or any chronic disease. So that can be a cancer, that can be a MS, that can be any from the IBD world, right? We know that 70% of people with IBD develop fibromyalgia and or IBS. So it very much goes along with some of our other conditions. And one of my greatest challenges in practice is teaching patients to recognize when it's your fibromyalgia causing the discomfort versus the chronic disease that's causing the discomfort. So I just wanted to highlight that.
No, I'm actually, I was going to ask you that exact thing. So I was like, why do so many people with rheumatoid arthritis or ankylosing spondyloarthritis or IBD also have fibromyalgia? So thank you for explaining that it is so common. But first, we're going to talk about the stigma or misconception that is surrounding fibromyalgia and has been for a very long time. And that is that, and I keep hearing this, is that the claim that fibromyalgia isn't a real medical condition at all, and it's just stress, anxiety, or something hysterical women experience. Even in 2025, fibromyalgia is
Oh,
still dismissed as a wastebasket diagnosis or treated as if it's all in someone's head rather than recognized as a legitimate physical condition. What would you like to say about that?
If you have ever felt completely lost or utterly alone while trying to navigate real life with rheumatic disease, listen up. I am here for you. I created an educational program to help you go from overwhelmed to confident, supported, and connected in a matter of weeks. And it's called Room to Thrive. After earning a master's in occupational therapy and completing hundreds of hours of additional training, I created a step-by-step guide to help you truly thrive with rheumatic disease. This is the only program I know of that's designed to improve quality of life for people living with inflammatory, autoimmune forms of arthritis, like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, non-radiographic axial spondyloarthritis, Sjogren's disease, and more. During the self-paced lessons, you'll learn how to manage pain and fatigue, cope with stress, navigate relationships, and continue doing the things that matter to you and bring you joy. The goal is really to help you improve your quality of life and learn how to thrive with your rheumatic disease right now, rather than waiting for a distant day when it might be cured or healed. I really created the down-to-earth, practical, heartfelt resource I wish I had had when I was first diagnosed at age 20. If you want even more in-depth support, you can join the 12-week Room to Thrive virtual support group, where you'll be surrounded by people who actually get what you're going through, people who will provide the encouragement, validation, and support that you deserve. Each group is expertly moderated, so you don't have to worry about the kind of misinformation that spreads like wildfire in the free-for-all social media groups. If you're on the fence, don't just take my word for it. Here's what Katie had to say in March 2023. I was lost and overwhelmed with my RA diagnosis. It felt overwhelming to know what to read, what to do, how to spend my energy trying to research on the internet. Room to Thrive did that for me. It's been like getting a crash course in my diagnosis along with a community who gets it. To see all the details, including the dates for the next support groups, go to the link in the show notes or bit.ly/thrive room with a capital T and capital R. You can also just email me anytime at info@myarthritislife.net. And don't delay if you're interested, because each group is capped at 16 people or less in order to make a small, intimate group atmosphere. Thanks so much for your time, and I can't wait to get started with the next groups. And I can't wait for those of you who are interested in the self-paced option to go ahead and join that at any time. Bye-bye for now.
Oh, I'd have lots to say about that. And I think one of the very first moments in my career as a rheumatology provider in realizing that fibromyalgia was in fact real was the functional MRIs that were released. And the first time a study was done on functional MRI was in 2002. But I want to go back because I want to say, and you first had to be able to identify characteristics that gave you or criteria that said you had fibromyalgia. And once we had that criteria, which was in the 1990s, we could then say, okay, this person has fibromyalgia, this person does not. And now I can study the differences between those two. And some of the very first things that they did before they got to functional MRIs is they literally used a manometer and they put pressure on an extremity. And they found that people with fibromyalgia said, ouch, at a lower pressure than people who didn't have fibromyalgia. And that was reproducible over and over again by multiple different sites, by multiple different researchers. So that was the first thing that they found, is that there was a different pain threshold for people who had fibromyalgia. They then, as I said, in 2002, it was Dr. Dan Claw and Dr. Grassley. They were the first to identify that when they looked at a functional MRI, which is an MRI that's examined under interaction with the patient. So whether you have someone look at an image or touch something or stimulate pain, it doesn't matter, smelling, any of those things. What they found is that people who had fibromyalgia, the brain lit up in a much more exaggerated way. When I first heard that, I was like, well, that's incontrovertible. We can't argue that. This is clearly different. And the exciting thing is that this has been also reproduced so many times that they now have something called a fibromyalgia signature. And this was in, let me give you the year for that. So it took almost 10 years before they were able to, let me just see, because I don't want to tell you the wrong thing. No, 2017, and it was Dr. Lopez. And she was the first person to identify this fibromyalgia signature. What that means is that someone who knows how to read these images can walk into a room, have no idea what that person is here for, but look at the image and say that person has fibromyalgia. And they found that it was exaggerated responses to all 5 senses. So taste, smell, touch, hearing, and sight. And to me, that was monumental. That was huge, right? But that doesn't end there. That's pretty significant. And I think that's enough. But then in between, let me get back to the date again, between 1990 and 2010, again, we were able to look at somebody who has fibro and someone who doesn't. And they started to look at, and this is through a series of multiple studies. But again, so substance P is absolutely something that transmits pain. So again, in fibro patients, the level of nerve growth factors, substance P, and glutamate is more than 3 times higher than someone who doesn't have fibromyalgia. So we're transmitting lots more information of pain to the brain. Then when the pain gets to the brain, there's supposed to be a bunch of neurotransmitters that are supposed to say, hey, this isn't as bad as you think. Don't feel that pain. So the enzymes or the hormones there are norepinephrine, dopamine, and serotonin. And most of us are pretty familiar with serotonin. It's what makes us feel well and gives us a sense of the world being okay. Dopamine is what the body uses to feel more focused and be able to pay attention. And norepinephrine is the hormone that we produce when our body is stressed. And we can all think of a time when we were stressed and we were able to accomplish something despite our pain, or something overwhelming because we were anxious that someone was going to be hurt and we were able to, they say, lift the car off the baby, right? That ability to do that is because you form this norepinephrine, and norepinephrine says, hey, don't feel that pain so much. So again, in fibromyalgia patients, these 3 hormones are all too low in their spinal fluid, which is why depression so often goes along with fibromyalgia, which is why dyscognition or brain fog often goes along with fibromyalgia. And it's where a lot of that pain comes from. There's a couple of other things that are off in the spinal fluid. They also found low levels of GABA. And GABA is the opposite of glutamate. And GABA is a substance that calms nerves down, reduces anxiety, and those levels are low in somebody with fibro. So again, you've got all this excitatory chemical that's going on, but not enough of the chemical that calms things down. And lastly, really high levels of endorphins are found in the spinal fluid of patients with fibromyalgia. Now, an endorphin, if you don't know what it is, it's your body's natural narcotic, your natural opiate, and it's what gives you pain relief, right? Well, if I'm just telling you that the levels are high in fibromyalgia, why do you still feel pain? Well, first of all, you make more because you do have pain all the time. So the body's like, whoa, I better make more of this. But you actually end up making so much that you don't have enough receptors for that endorphin to connect to. So for most drugs and chemicals to work in the body, they have to attach to a receptor. When they attach to the receptor, then you get the benefit from that agent. And the thinking is that there's been an overcrowding of the receptors. And so then you make the drug, or you're making this endorphin, but it doesn't have any place to attach to, and therefore it doesn't give you pain relief. Which is, and this is really important to hear in the world of fibromyalgia, there's lots of evidence that opiates, so exogenous endorphins like oxycodone, Dilaudid, all those medications that for a while we thought there was no ceiling. We thought we could give you as much as we wanted because you needed it for your pain. But what we realized 10 years ago when we were giving way too many of these is that people with fibromyalgia were the ones who needed higher and higher doses, and they weren't getting pain relief. In fact, we were making them more sensitive to pain. We were increasing something called hyperalgesia. And so we know now that's because all those receptors were maxed out before we even gave them the medicine. And all they were getting from it was more side effects and then this hypersensitivity to pain. So that's pretty huge. And to me, knowing that spinal fluid is different helps me to, again, have an objective piece of evidence that something is wrong, something is different in patients who have fibromyalgia. There's a few other really important things that came along from a research perspective. In 2004, we actually found that when you, again, could measure those who had fibro and those who didn't, and then look at their families, they found that there was a pretty strong genetic predisposition for fibromyalgia as well. And that genetic predisposition can be as high as 30 to 40%, depending on the studies that you look at. And then in 2013, there was a publication, one of the first, and this has also been reproduced by Dr. Uceyler et al. And they found that there was more incidence of small fiber neuropathy in people with fibromyalgia. As much as 60% of people with fibromyalgia, small fiber neuropathy is little teeny nerves that exist right underneath your skin. And when those nerve endings are disrupted, so they're supposed to be nice and even and straight and organized, but in fibromyalgia, they become completely disorganized, which makes sensitivity to touch such a significant issue. So that was a big finding. And then I think, to my understanding, one of the next best, most significant findings was in 2015. And again, this study's been replicated multiple times, but the first study was published by Dr. Brummett, and they looked at all patients going for hip and knee replacements. And they found that patients going for knee replacements who had scores, so there's a way to calculate your fibromyalgia score. And this was all patients, whether you had fibromyalgia or not. And they took those patients who had a score over 13, which was consistent with fibromyalgia. And they found that those with a score over 13, for every point over 13, they needed 9 more milligrams of morphine postoperatively. And 6 months down the road, again, for every point over 13 that you had, you were doing worse postoperatively than those who didn't have fibromyalgia. So those are my key big research findings that, at least in my mind, helped me to understand that there is something absolutely connected and something different in those that have fibromyalgia. I didn't talk about the sleep studies, and there's multiple sleep studies that have been shown to demonstrate that there's a disruption in normal, deep, restorative sleep for patients with fibromyalgia. And just as well, the very first study in 1975 was published by Dr. Moldavsky, who said there's a connection between sleep and pain. And they found that taking healthy college students and disrupting their sleep over the course of 1 week led to increased pain. And after 2 weeks, they felt like they had fibromyalgia. I'm sorry, that was a long answer, but there's my objective evidence.
That was an incredible answer, and you provided so much evidence. So thank you for that, because it is a massive stigma that fibromyalgia isn't real. So thank you for providing all that information to us. Cheryl is going to move on to our next misconception about fibromyalgia that you can answer for us.
Yeah. And you did already touch on the potential associations of what causes fibromyalgia. I think that is kind of like a chicken or the egg thing. Did they come out of the womb like this, or does something happen? Like with RA, it's kind of like they say genetics loads the gun and environment pulls the trigger. Is it like that?
Same thing.
Okay.
Absolutely same thing. And there is definitely a connection to some trauma. So some of the literature that you look at can tell you that 90% of people who suffer from fibromyalgia have some trauma somewhere in their life. Now, how you define trauma is very different, right? It can be emotional trauma, physical trauma. It can be a surgery that's gone bad. I just had a patient who just had a abdominal surgery and her pain was so severe. I'm talking to her 2 weeks later. I swear to God, she just had a PTSD experience. I mean, so it's any kind of trauma, and that then often turns it on. So frequently what we'll hear from patients is, I was fine until I had that car accident, or until I had that fall, or until I was diagnosed with rheumatoid arthritis. And I think, to the best of our ability, what I can explain to patients is that acute and chronic pain are different. And when you have pain that goes untreated for a long period of time, it becomes a chronic situation. So acute pain over 3 months, completely untreated, leads to centralized chronic pain issues. And that's why oftentimes people with an ankylosing spondylitis or spondyloarthropathy, these patients go for upwards of 10 years, even lupus patients, Sjogren's patients, right? They go for more than 10 years before they have an accurate diagnosis, during which all that time they're having an inflammatory or just a chronic pain state, and that's changing their processing of pain. So I think that's really important to understand about what turns it on. But I also like to talk about the fact that there are modifiable factors that turn on pain, and there are non-modifiable factors. So I obviously can't change the fact that you developed rheumatoid arthritis. I can't change the fact that you've maybe even had a horribly traumatic childhood, right? So let's talk about the things that you can change. We know across the board, every patient that's been interviewed with fibromyalgia says their symptoms are much worse when they're stressed. So we know we can manage stress, right? We also know that obesity, which is a growing problem in our country and across the globe, we also know that leads to inactivity and isolation from the stigma associated with obesity even. And those things then lead to exacerbation of symptoms. So when it comes to the whole question of depression and or anxiety, it's always hard to know which comes first. It could be many people who have depression and anxiety have somatic symptoms that look just like fibromyalgia, but then many people don't have any depression or anxiety initially. Then they go on to develop chronic pain, and the chronic pain makes them have depression and anxiety. But I have two rules when it comes to treating fibromyalgia. My first rule is that if you don't sleep, if you don't get high quality restorative sleep, and that means a minimum of 4 hours of uninterrupted sleep a night, you will not control your pain. And the second rule is if you have anxiety and depression or depression, and it's either pre or post, it doesn't matter where it came from, but if you have it and you're not addressing it, you'll never take care of your pain. So those are my first two rules when it comes to treatment.
Wow. You must have read our outline because you perfectly anticipated the next question. And I think I'm often on my soapbox. So yeah, sleep is the forgotten lifestyle intervention. Everyone's like, diet, exercise, diet, exercise. And I'm a huge, especially right now, exercise, strength training person. But sleep, people just forget.
Well, I'm going to second the sleep thing. I've been having issues sleeping lately. So yes, it's definitely set my fibro. So you touched a little bit on what can help people when they have fibromyalgia. Sleep and addressing mental health. I lately have been going on trying to prioritize my mental health as much as I prioritize my physical health, because really they are the same thing. To feel better with all the arthritis I have, quite a bit, I need to also address my mental health. But there is a very major myth about fibromyalgia, and that is that it can be cured or treated with a specific diet, supplements, or by blaming things like leaky gut or your diet changes in your mindset or exercise. All these things can either cure or completely relieve fibromyalgia. What would you say the truth behind this is, or the not so truthful facts about
So,
it?
what I would say across the board, for the most part, in most individuals, some people, there is one thing that's going to make them better. But for the majority of people, it is a constellation of treatments. There are far more things that you have to do than to take one drug or one diet or one supplement or one exercise regimen or one even behavioral health approach, right? It really is a lot of different things. And I did not come up with this analogy. Dr. Penny Cowan is the director of the American Chronic Pain Association, and she came up with the analogy of living with chronic pain is like driving your car with your tires flat. And I use this all the time with my patients because to move smoothly through life, you have to have all four of your tires full, right? Well, one tire is Western medicine and surgery and interventions and things that we do to you. So it's getting you on the right medication. It's making sure that I give you the right injections if you need injections, operate on what it needs to be operated on. That's what one of those tires is. But if that's the only thing I focus on, I still have 3 flat tires. The second tire is your physical strength and endurance. So that means the food that you put into your body, the sleep that you get for your body, the muscle mass that you maintain. all of that is just, again, a whole nother tire. So if I eat right, sleep right, exercise, and I take the right medicine, but I still have the other two tires I'm not focused on, I'm not going to be rolling smoothly through life. The third tire, and I may have tweaked this from her description, so it's the way that it works for me. The third tire is your social worth and value in our planet, right? So it's the connections that we maintain with others. We know that connections are critical. If you have to change the way that you work, that's fine, but you still should feel like you're contributing to society. You're maintaining those friendships. And how many times would I ask a patient who lives with chronic pain, when was the last time you did something fun? It's quite scary when I see that they can't even remember. So maintaining those social connections is critical. That's a whole tire in and of itself. And then lastly, so you can do again all that and have it all perfect, but you still have a flat tire if you're not focused on that last one. And the last one is called coping strategies. It's what are the tools that you have in your back pocket that you on your own can pull out without anyone else's help. So it's knowing how to do a deep breathing exercise, knowing how to meditate, knowing how to pace yourself, knowing that if I need to go clean out that closet and I think I can do it in 1 4-hour chunk of time and I'm not going to be in pain for 3 days, that would be an inappropriate expectation. But to know that, okay, I got to clean out the closet. It's going to take me 2 weeks and I'm okay with the mess that's going to be there until that's completed. That would be a healthy self-management strategy. Self-management is also the ability to change thinking that's not working for you. We didn't talk about catastrophizing. We mentioned before modifiable and non-modifiable causes. Many people who live with chronic pain catastrophize. So for example, this woman who had terrible abdominal pain after her surgery and thought, oh my God, I'm never going to be better again, ever in my life. That is a catastrophic thought. She also was panicking about having to have open heart surgery. She doesn't have any cardiac problems, but she said, what am I going to do if I have to have open heart surgery? She was catastrophizing. That's when you have a headache and you think it's a brain tumor. So learning how to change those thought processes is a self-management technique. And so to sum it up, it takes all of that to get well. It is not one strategy. It's all of that.
That's so helpful. And sorry, I'm just going to fixate on the catastrophizing for 1 second, because I am on the record as saying that in the wrong hands and without the strength of like your therapeutic alliance, learning about pain catastrophizing can very much come across as gaslighting, but that is in the context of when it's not applied in a very compassionate way and it's not explained in the way of like you said, she's worried that her pain's never going to get better. Well, we don't have proof either way. We don't actually have proof, right? So we could build our capacity to cope with the uncertainty and learn to direct our focus away from this idea that I have to know for sure how much pain I'm going to have and that like anxious.
You're never going to know for sure.
But but if an untrained person had said to me, well, let's just make a chart and see whether the evidence, it's like, that's not going to help me. It's going to make me feel like you're just saying that I'm not thinking correctly about my pain's effect on my life. You know what I'm saying?
So here's a way that I also, in that I'm hoping this is in a learned way, at least it's how I understood it. Yes, you want to challenge the thoughts, but sometimes those thoughts still lead you back to, yeah, I think I'm going to be in pain this bad for the rest of my life. The last question I have people ask themselves is, how is this working for you? Is it working for you to maintain that very negative approach? And even if that pain is always going to be there, how I change my response to that pain. And that's another thing about acute versus chronic pain. And I typically, when I do this talk, I explain to patients that acute pain, if you look at a pie graph, acute pain is 75%, or 75% is the acute tissue injury, and how you think about it and how you feel about it is the whole pain experience. But chronic pain, 75% of that experience of pain is your thoughts and emotions. And a very small piece of the pie now, less than 25% of the pie, is actually the tissue injury that you have. So while, again, I can't change the tissue injury per se, I have you on all the drugs I need to control your inflammatory arthritis, but you still have pain. I can help you change your thoughts and emotional response to that pain, which is a huge part of the pie. And so that's where some of those thoughts come through and how you can make a difference for yourself.
100%. That circles back beautifully to Eileen's first kind of question, right? Which is, what if you have both fibromyalgia and rheumatoid arthritis, I'm experiencing pain. Which one's causing what?
That is a very common I
Yep.
guess, contemplation I have every day. Is this rheumatoid arthritis pain and fatigue and cognitive dysfunction, or is it caused by fibromyalgia? So it's a constant battle trying to pinpoint which one. How did I throw myself into this flare?
So that's a question I have to work with my patients very aggressively on a regular basis because you have to know the difference because how we treat those are completely different. If your RA is flaring or your inflammatory bowel disease is flaring, I'm going to use disease modifying agents to fix that problem. But if it's your fibromyalgia that's flaring, I'm going to use whatever is needed in that case to figure it out. And how you largely make the distinction is based on a word that I really try to help patients understand, and that's function and stiffness. So the typical patient will tell you, I'm stiff all day. But then the next question you want to follow that up with is, what is your range of motion? And so, Eileen, I know you can recognize this, and you too, Cheryl, because you both have an inflammatory arthritis. When your joint is inflamed, you lose the ability to range in all the planes that it needs to go. So you maybe can't raise your shoulder up, or you can't bend your wrist, or you can't make a fist. Those are all signs of inflammation. Whereas somebody with fibromyalgia will have pain and they'll say stiffness in all of those places, but they'll be able to move their joints in all planes. So that's the biggest difference. And it's not easy for people to understand that. The other thing is I have a lot of patients with fibro will say, yes, my joints are swollen. And the next question I say is, could someone from across the room see that swelling? And if you could see the swelling, it's clearly inflammatory. There is some subclinical inflammation that happens in RA, like when someone squeezes your hand, they give you that handshake and that hurts. So when it becomes really difficult to distinguish, I then will use advanced imaging. So I'll do an ultrasound and I'll evaluate your joints with an ultrasound and see if there's increased blood flow to that region, which suggests that it's your disease that's flaring. And if all that comes back negative, or I'm able to see without having to do the advanced imaging, then we address the problem from a fibromyalgia perspective. And sometimes you have to do both at the same time.
Yeah, and the other thing I say, if someone's just, and sorry if I missed this, but is just that typical pattern of worse in the morning is for our RA really, and getting better with activity. At least for me, my RA for the last 22 years has been very predictably like, this is my first sign of a flare, like canary in the coal mine. It's worse in the morning, gets better throughout the day. So
can you speak to that issue? I'm guessing you can speak to this. When it's your RA that's flaring, yes, you're stiff in the morning. Fibromyalgia, but it gets better with activity. Fibromyalgia stiffness doesn't really get better with activity.
No, and it can be very kind of confusing to tell which one's which, especially because I also have osteoarthritis.
Yeah.
So it's like, okay, how do I tell the differences? I find for rheumatoid arthritis pain is very joint centered.
Is it?
And my joints feel hot, they feel stiff, they're achy. But fibromyalgia pain is like you feel it all over your body or kind of centralized in certain areas, mostly in the muscles.
Yep.
And I also find that it is sometimes also easier to trigger from exercise and things like that because there's post-exterior malaise or is it post-exercise. I forgot the word for a second because I'm very brain fogged. So there's just like little things about that I've had to learn about kind of the differences between, is it my fibromyalgia or is it my rheumatoid arthritis? And also I believe that I had fibromyalgia before rheumatoid arthritis, mainly because I come from a background in my childhood with trauma and things like that, as you brought up. So understanding all of that has helped me kind of really understand my triggers for fibromyalgia flares, because a lot of it is coming from my past traumas, my mental health and stress, where rheumatoid arthritis can also be definitely exacerbated from stress and depression, but it hits differently physically.
Also, sometimes, not always, the blood test can also be helpful. With a fibromyalgia flare, you should not see elevated inflammatory markers versus with inflammation.
And once upon a time ago, I was near remission with rheumatoid arthritis, and my CRP and my blood work was fantastic, but I still had pain.
Yes.
And my rheumatologist said something very profound to me, and that was, let's not look at the blood work. Let's go by how you are feeling. And that's when she actually sent me to another rheumatologist who was a specialist in diagnosing fibromyalgia. And that's how I received my diagnosis.
And you asked about treatment. That's one of the most important treatments is to get a diagnosis, to feel
Absolutely.
validated, and then to do education to understand the condition. So when we look at the guidelines for treatment of fibromyalgia, that is the very first thing is to validate someone and then to educate them, which is what you guys are doing here. And I thank you very much for that.
Thank
And
you.
so we are going to have to move on to our last question, which I think is an important one. And even though I live with fibromyalgia and I have been for over a decade and over a decade of living with rheumatoid arthritis, it is so hard to describe what exactly is fibromyalgia to our friends and family in a way that they would understand. So the last question we have for you here is, how would you suggest somebody describe fibro to their friends and family?
So, first of all, I would say ask them if they've ever had a period of time when their sleep was really disrupted. If they had 3 to 5 days of poor, non restorative sleep, how did their body feel? Ask them what they feel like when they're getting a cold. That horrible total body pain, muscle aches everywhere. Remind them that it is a condition that causes pain above and below the waist, the left and the right side of the body, associated with headaches, stomach discomfort, brain fog. So I would say all of those things to help them understand. And then I really love the work by Christine. I don't want to mess up her name.
Yeah.
The spoon theory. So she is all about helping people and her family understand these conditions that you can't see. If I looked at either of you, I would never know either one of you is dealing with any chronic condition. But basically, it takes energy to get through your day living with these chronic states. And so that's what she explains in her spoon theory is that we're all given maybe 50 spoons to start the day with, but just to get out the door, if you have an inflammatory arthritis and or you have fibromyalgia, and they're both just as disabling, right? You've used already 30 or 40 spoons before you walk out the door. So that seems to help people understand. I don't know if that's a good enough answer, but that would be my explanation. And I really encourage people when I do my lectures for the community, I always say, bring a family member. I want someone else in your family to understand this. It's very hard for family members because you look at fine, your function level is often totally fine. And they think, well, why are you complaining? You look fine. What's the problem?
Oh, absolutely. Yeah. And thank you so much for that. And I mean, you've had so many great nuggets of wisdom. We're always thinking about which parts of the podcast can we clip and do like a short social media clip. And I'm like, you know what? Social media, I'm sorry. You guys are all going to have to listen to the full episode, okay? Because there's too many to clip. But is there anything that you would say is the most important takeaway you'd want someone to take away from this episode?
Well, I had 3 that I listed for you. One is that it's real. You 100% need to believe that it is real. And I gave you just a very cursory explanation of the evidence, but there's mounting evidence. And every year there is a paper and it's written by different people every year. It's called Fibromyalgia, 1 Year in Review. The last one, the author was D. Carlo. But if you just search Fibromyalgia 1 Year in Review, every year there's a paper published. It goes through what we understand from the pathophysiology, what we understand from the mechanisms of the pain, and then treatment options. So it's perfect for keeping up to date with the research that exists around the world of fibromyalgia. And then my second most important thing I would want to leave people with is that, again, it isn't one treatment. There is not a drug out there that's going to fix your problem. There's not a diet out there that's going to make it go away. There's not an exercise that you can do, except you have to do it all. And I also think it's very important to know that we as healthcare providers are really just here to coach you. It's also crazy important that you take responsibility for yourself and you lead the show. You are the leader of your body and you have the ability to make the changes that need to be made to get well.
Well,
Yes.
you're in the driver's seat, and I would say with great power comes great responsibility. It's kind of great, good and bad news, right? Because I think it's almost like a grief process when you're diagnosed. Like you want the doctor to or the nurse practitioner, just give you the magic bullet. And it's kind of good news, bad news to learn that, oh, I'm the one that's going to be dealing with this every day. And I'm in charge of my destiny to some degree. I don't have the spoons for this sometimes, but I would say just take it one day at a time and you will learn how to be that driver. It's like going to driver's ed. You'll learn with your coaching from your providers and your fellow patients and your support communities, hopefully.
I actually never learned to drive because of my brain fog.
Okay. Like literally
It
drive.
doesn't really work for me.
Oh,
but
no.
I just like to say, Eileen, no one else is going to hold your hand but yourself.
No one else is going to dress you. No one else is going to get you onto this podcast. You had to do that all yourself. The same thing.
Exactly. So that is definitely something that is really important to realize when you have fibromyalgia, but also mental health struggles as well. Because then I feel like then you're also fighting your body and your mind at the same time.
The interview, just one last little tidbit, the interview of Oprah Winfrey and Lady Gaga, if you've not seen it, is spectacular. So they do an interview, I think it's over an hour long, talking about fibromyalgia and the trauma and the need to treat the trauma as one issue and the fibro as another issue. And the fact that you do need to use medicine sometimes, but it needs to be the right medication. And you need to know when you're supposed to use it and when not to use medications. I thought that she does a beautiful job in that description and would highly recommend everyone listening to it.
Okay, I'll put a link to that in the show notes. Yeah.
And that actually kind of fits perfect into our last little tidbit here. And if people want to learn a little bit more about fibromyalgia, where do you recommend they go?
So there is an association, Fibromyalgia Awareness Association. I think it's FAA. They are a place where they catalog a lot of the research that's being done. They have lots of resources, and I think there's support groups that come there. I actually send people to you guys. Really love the work that you're all doing. And then the American Chronic Pain Society would be another place, but the University of Michigan, their Chronic Pain and Fatigue Center is really where the science is coming from. They're kind of an international hub for the research that's being done. And then one of the greatest tools that we have at our hand is that Chronic Pain Reset book by Dr. Afton Hassett. And she now has a podcast as well. So her podcast is fantastic. She too tries to keep it a half an hour long and goes into a variety of different topics. And she is working on a workbook to take people through for exercises. She's a world-renowned clinical psychologist focused on pain, and she's taking her career of experience and applying it to this one book. And the book goes through the first half is with case studies and how they've come out of their bedridden level of severe pain. Thank you for pulling up the book. CPR for pain to me makes so much sense.
I never even noticed that. I love it.
So anyway, it's a great resource. She's always updating things. So that's what I'd like to leave you all with.
Excellent. Yes, I also have that book and I have seen her speak. So thank you so much. And on that note, we are finished today's topic on fibromyalgia, though we could probably talk for several more hours. Thank you so much for being here. And thank you again for listening to another episode of Rumor Has It.
Yeah, and don't forget to check out the full show notes on the Arthritis Life website, myarthritislife.net, for the full transcript plus video of our conversation.
We would also love to hear what you think about this episode. Shoot us an email or comment on our social media accounts.
Thanks again. Bye-bye for now. Thank you so much for listening. This podcast is supported by Room to Thrive, an educational program I created to help empower you to live life to the fullest with rheumatic disease. In the program, you're going to learn evidence-based tools for managing all the ways rheumatic disease affects your life. And my goal is to help you go from overwhelmed to confident, supported, and connected in a matter of weeks. You can go through the pre-recorded modules on your own in the self-paced course, or you can take the course along with a robust support group of new arthritis friends to support you and cheerlead you along the way. Learn more in the link in my show notes, or you can always go to www.myarthritislife.net. And if you like this podcast, I'd be so honored if you took the time to rate and review it. I also encourage you to share it with anyone you know who might benefit from it. I also want to remind you that you can find full transcripts, videos, and detailed show notes with hyperlinks for each episode on the Arthritis Life website, plus full episode videos on the Arthritis Life YouTube channel. If you have any ideas for content for future episodes, or you want to share your story on the podcast, please send me, Cheryl, an email at info@myarthritislife.net. I can't wait to hear from you, and thanks so much again for your time.